Welcome to the Rise and Thrive webinar series, Best Practices for College Communities in the Time of COVID-19. As some of you know, Rise and Thrive is a project developed through funding from the Governor's Emergency Education Relief Fund under the Coronavirus Aid, Relief, and Economic Security CARES Act, Mental Health Coordination. OCI, housed at Prevention Action Alliance, is a partner in this project with the Ohio Department of Mental Health and Addiction Services, Prevention First, the Ohio Program for Campus Safety and Mental Health, and the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery. Rise and Thrive webinars are developed to promote campuses and communities working together and provide the opportunity to engage with state and national experts on topics that promote campus and community partnerships and enhance student wellness. These webinars will be at no cost to participants, and CEs will be offered. Webinar recordings, announcements, and registration will be available on the OCI page and announced through the OCI network listserv as well as other platforms. Today's webinar will focus on COVID-19 vaccines addressed by medical expert Dr. Thomas Feil. Dr. Thomas Feil is chair of the Infectious Disease Division and co-director of Antimicrobial Stewardship, sorry if I chopped that, at Summa Health in Akron, Ohio, and professor of internal medicine, master teacher and chair of the Infectious Disease section of Northeast Ohio Medical University. Thank you for allowing us to have your expertise, Dr. Feil.
Well, thank you very much, Juliana. It's a pleasure to be here and discuss this issue of COVID-19 and specifically to focus on vaccines, because as I say in the title slide here, this is the way out of the pandemic. And we're already starting to see that as we see changes in public health guidances. Now, if I could have the next slide, Brittany. I just want to start out with some disclosures. I have no financial disclosures. Many of my slides, however, come from bi-weekly conference calls that I have as a member of the Infectious Disease Society of America and the CDC. But I also want to comment towards the last part of this slide that there's rapidly evolving information. And actually, some of what is stated in this slide, or these slides, which I submitted more than a week ago, there's already significant changes, and we're going to see that as more come in the future. But I'll highlight those as we go through the presentation. So the next slide, please. Now, I want to start out just with some review of the history of COVID-19. I mean, this is literally only a year and a half that we've known about this. I mean, it was sort of identified in December of 2019 as this coronavirus, a novel coronavirus. And we say novel because obviously nobody on Earth actually was immune to it, so everybody was susceptible. And it's somewhat similar to the other novel coronaviruses that we've observed in the last 20 years, the severe acute respiratory syndrome, which was SARS-CoV-1 back in 2003, and mainly just in China, although it did go to other parts of the world, including even Canada. And then more recently, the Middle East respiratory syndrome, which is primarily in the Arabian Peninsula, Saudi Arabia, etc. These are novel coronaviruses, but I want to compare them. We do have endemic coronaviruses that we've been dealing with for the past many decades, usually associated with mild respiratory infections, such as the common cold. But these are different. Obviously, you know that COVID-19, which is disease associated with this SARS-CoV-2, can be very serious. And then we've seen evolution of these variants, which are slight changes in the lineages of this particular virus. It's not a different virus, but it's just a little bit different form of it. And I'll talk a little bit about that, how it impacts the vaccine efficacy as we go through here. One thing about transmission, we know that SARS-CoV-2 is somewhat more transmissible or more contagious than influenza. And so that's a bit of concern. We have risk factors, and this is something very important, that obesity is a significant, probably the most significant risk factor for serious complications. But if you go to the right-hand part of that risk factor row, hypertension, that's HTN, that refers to hypertension, is also a bit of a risk factor. And that's a bit unusual. We don't necessarily see hypertension as a risk factor for pneumonia or respiratory infection. But I've emboldened the next comment, and that's asymptomatic spread, because this is what has made the difficulty in containing this particular pandemic, because we now know 30, 40% of patients who are infected and can transmit it don't have any symptoms or asymptomatic. And so it's difficult to stop the spread if you can't identify those people who are sick and then maybe isolate them or quarantine them. That is the whole premise about why we all had to wear masks, because we didn't know if we were potentially infected and we wanted to prevent transmission by wearing the mask. Now, the manifestations of COVID have changed, at least as our understanding, over the past year and a half. If you recall, basically back March, April of 2020, we were focusing on some more severe cases. So if people had one of three manifestations, fever, cough, or shortness of breath, that's what SOB is. But now we know that almost any symptom, it can even be gastrointestinal symptoms, it can be rashes, it can be loss of smell or taste, can be associated with this virus. We now know that there's a variety of ways in which the virus caused these manifestations. It's direct infection into the specific organ from the virus, or it can be the immune response of the host with the inflammation that is put forth by the host, or potentially hypercoagulation. All of these can be the pathophysiology in which these manifestations occur. And then a hallmark of COVID-19, which is a great concern, is that we now know that a lot of patients who even had mild infection can have long-term persisting effects. And I'm talking about 6 or 7 months. And that is going to have a significant impact, I think, on medical care of our patients. We do have now some therapeutics that we can treat patients. So we have some specific antivirals, we have monoclonal antibodies and anti-inflammatory agents. But I'm going to come down to control and prevention. How are we going to eventually control this? As I said, it's going to be through vaccines and through masks, but specifically through vaccines so that we can stop the spread. And as I'll go through here, how the vaccines will do that. So next slide, please. So just to give you a little bit of a sense of the pathophysiology and the stages of infection, if you look at the boxes up on top, about 80% of patients either have asymptomatic infection or very mild disease who do not require coming or having to be hospitalized into a hospital setting. Only about 20% require hospitalization. However, we do know that, tens of thousands, hundreds of thousands have been required hospitalizations in the United States alone. And so that's very important to be aware of. If you look at the middle of the slide, most of the manifestations of the milder cases are due to the viral replication, whereas the severe disease, in much of the part, is due to the host inflammatory response. And down at the bottom, I just showed that we have antivirals that can interact with the viral infection, and we have inflammatory markers or inflammatory interventions to deal with inflammation. So we are much better equipped to treat patients now than we were even a year ago. Next slide. And then before we get specifically to vaccines, I just want to highlight that several societies or agencies such as NIH, or in the first column, the Infectious Diseases Society of America, that's what IDSA is, have developed the guidelines of the use of some of these interventions. And I just want to point out a couple of them, because you may recall a year ago, a lot of people were using hydroxychloroquine. There was a lot of interest in it. There was a thought on the basis of very limited data that it might provide benefit. However, as we became aware of very well-controlled trials, it became quite clear that this agent did not provide benefit for patients who were infected with SARS-CoV-2. And as a matter of fact, maybe caused harm. So you can see that both the Infectious Disease Society of America and the National Institutes of Health in their guidelines recommend against using that. However, you can also see some of the highlighted, emboldened interventions, and specifically I'm going to talk about remdesivir, dexamethasone, and monoclonal antibodies. They all have been shown to be beneficial for various stages of infection of COVID-19. And then the one under monoclonal antibody, that's IL-6 inhibitors. These are specific medications that reduce the inflammatory response by a host. They have also been shown that in seriously ill patients who have progressively severe disease to reduce morbidity and even reduce mortality. Next slide. So let me get to what we're hoping was going to get us out of this pandemic, and that is the vaccine. I mean, I took this from New York Times, I guess about 2 weeks ago here, or a week and a half ago, where it states turning the corner. And hopefully we are doing that right now as we see more and more people being vaccinated and therefore protected and reducing transmission. Next slide. So let me go through some of the characteristics of some of these vaccines. And I've put up 4 of the vaccines here, 3 of them that have already achieved or been designated by the FDA as emergency use authorization. These are not officially approved, but they are authorized under the auspices that this is a public health emergency status. I've also included the AstraZeneca, which is available in many parts of the world, but not in the US. But you can see that for all 4 of these, the target of the vaccine to which antibodies are developed is the spike protein part of the virus. And I'm going to show that in a little bit of in a second. So all 4 of them have that as the target. Now, the technology is a little bit different, and you may have heard about the Mrna and the Pfizer being these mRNA vaccines. These are a technology that's been developed over about the last decade, and there's a lot of experience with it, but this is the first time in a large mass immunization that this technology is being used. And it's associated with tremendous effect, and we'll talk about that as we go through here. Whereas the J&J and the AstraZeneca are a little bit different. They're what they call a vector vaccine, and I'll explain that as well. As far as the logistics, both the Moderna and the Pfizer require freezer for storage and transportation. Initially, the Pfizer, you may have heard, required ultra cold conditions. However, that's been revised that it just requires freezers now. Whereas the J&J and the AstraZeneca only require a refrigeration, which is going to be much easier when you go to parts of the country or the world where the freezers may not be available. Now, the other point I want to make about this slide is that you're probably aware that the Moderna and the Pfizer require 2 doses, whereas the J&J only 1 dose. And again, from a logistical standpoint, that is a bit of an advantage of the J&J vaccine. Next slide. So I mentioned that the target of the vaccines are the spike protein, and that's sort of that spike that's showing out of the surface of this cartoon or this structure of the virus on the left-hand part of the slide here. This is critical for the function of the virus because it's that portion of the virus that attaches to receptor sites in our cells or on our cells that allows infection to occur. So if we can interrupt with that and have antibodies that neutralize this spike glycoprotein, then we can stop infection. Next slide. And this is what I'm going to show in this next slide up on the left-hand part of this slide. As you can see the spike coming out of the virus, and it attaches to the specific, what we call angiotensin converting enzyme, or ACE2 receptor sites. And this is where we interfere, where the vaccine develops antibodies, neutralizes that effect, does not allow the virus to attach to the cell. Therefore, the virus cannot affect the cell and go through the whole life cycle that is shown on the right-hand side of the slide. Next slide. let me comment a little bit about this messenger RNA because it is relatively new, but let me just stress again that this has been a technology that's been in evolution for at least a decade, even longer than that, because there are other vaccines that have been looking at this type of technology. This kind of technology allows for a much more rapid development of a vaccine, and that is why the vaccines have been developed so rapidly. I mean, when you think about it, the virus was only sequenced a year ago, January. Here it is in May of the next year, and we have hundreds of millions who have already received the vaccine and benefited from it. But the messenger RNA, this is the sort of the genetic code that is carried into our cell that stimulates our immune cells to produce the antibody. This is specifically the genetic code. It's actually encapsulated in a lipid envelope. The lipid it goes away, and then the RNA stimulates the immune cells to make the antibody. There is no interaction with DNA. There's no alteration of our DNA with this particular virus. And I said that at the bottom of the slide that although the use of technology, it is new, but it's not unknown. I mean, various other viruses, or excuse me, vaccines have been studied, including even influenza, using this technology. And I also want to point out that the clinical trials that were done with all of these vaccines were very carefully conducted on the basis of high quality scientific criteria and for safety and efficacy. So that we just need to be aware that these were very well conducted studies before they were actually even authorized to be used to be administered to the public. Next slide. Now, you know that the Pfizer vaccine is available, at least initially, for anybody over or 16 and above, but as you probably are aware from last week, subsequent to the presentation of my slides anyway, the FDA has now approved the Pfizer vaccine down to age 12, and that's adolescents. So that's going to be kind of important because we now know that about 20 to 25% of all documented COVID cases are in children. And children can, although probably less than adults, but children can transmit. And so if we can get particularly adolescents, which are probably of all the children, those that are more likely to be infected or transmit, if we can get them vaccinated, that's going to be very helpful in reducing the spread within the community. Now, Mrna is also planning to approach FDA for an authorization because they've done a study with children down to age 12 as well. Both of these are 2-dose vaccine. Initially, Pfizer was 3 weeks apart, Mrna was 4 weeks apart. However, if you go down to the bottom, the CDC guidance is that we can actually, if we have to, we can delay it up to 6 weeks. Next slide. Now, as far as the vector vaccines, this is a little bit different technology. It's somewhat older. That's where you insert the genetic code, in this case, the RNA of the coronavirus, into an already established virus. And both of the J&J and AstraZeneca use a adenovirus, but it is a adapted adenovirus that cannot replicate. So it in and of itself cannot cause infection. So it's just, the purpose is to be injected into the host cell. It releases the genetic code for the spike protein for the coronavirus SARS-CoV-2. And again, the immune system develops the vaccine. The antibodies for neutralizing the virus. Next slide. Well, what about efficacy? This is extremely important. And I want to point out that these vaccines are extremely, remarkably effective. I mean, if you look at the clinical trials from Moderna and Pfizer, the efficacy overall in preventing clinical disease was 94% and 95%. I mean, that's almost unheard of. I mean, most vaccines don't even come close to that. If we look at influenza vaccines, for example, maybe 50% at best. Although, like the COVID vaccine and influenza vaccine, even if you were vaccinated and do become ill, in general, it's going to be a less severe disease. Now, if you look at the J&J, it's at least in the United States, it was 72% effective in preventing disease. I'm not going to talk about the AstraZeneca because we don't have that in the United States. But if you look at the second row, efficacy in preventing severe disease, that means patients who are sick enough to have to come in the hospital. And as I already said, if you were vaccinated and you did get an illness, usually it's mild and it didn't require hospitalization. Well, all three of these US vaccines, Moderna, Pfizer, and J&J, prevented severe disease or prevented patients in their clinical trials from having to come into the hospital if they received that vaccine compared to the placebo. And then the next row is extremely important because we did not know this initially. And that is, does the vaccine or do these vaccines prevent asymptomatic infection and therefore prevent transmission to others if they don't even know they were sick? And the answer is yes. Now, we have indirect evidence. I mean, the Moderna trial actually swabbed for the presence of the virus everybody before they got their second dose, even if they didn't have symptoms. And they showed that those patients that had that did develop asymptomatic infection were much more likely to be in the placebo arm than the active vaccine arm. Data from Israel, where they used primarily the Pfizer vaccine, showed significant reduction in transmission. And similarly, seroconversion studies where you look at patients, even though they aren't sick, you can tell if they were infected by doing antibody determinations, again, showed that even the J&J vaccine prevented transmission or asymptomatic infection. Now, the last row is the side effects. And I'm sure many of you are aware that these viruses, all of them in the United States, are somewhat reactogenic. By that, I mean, there is a relatively high incidence of side effects, but these side effects are generally mild and they're transient. There's going to be local discomfort at the site of injection. You can have some fatigue, headache, muscle aches, maybe low-grade fever, but these only last about 1 or 2 days. And as I tell patients, that just means that your immune system is working well. And so you're going to develop a good level of antibodies to protect you. Now with the J&J, I've got it under their side effect box there, CVST. Well, that just means cerebral, venous, sinus thrombosis, which you may have heard about. And I'll have a little bit of comment out about that somewhat later. Next slide. And I want to point out that because there's been some discussion, well, should we only use 1 dose of these mRNA vaccines? And if you look at the second sub-bullet point for both Pfizer and Moderna, you can see that the efficacy is not anywhere 95% or 94%. It's 52% and 69%. And I want to point out that the first dose really primes the immune system. It's really the second dose that gets you the high level of antibodies that keeps you very protected for a long period of time. And this is extremely important now because with our awareness of these variants that in some way may reduce the level of antibodies, we need the high level of antibodies to be effective against these variants, which fortunately they are, as I'll talk about subsequently as well. Next slide. Now, I already mentioned the side effects that can include fever, headache, and muscle aches. But in general, these are well tolerated. You can use antipyretics, Tylenol, or ibuprofen to ameliorate them. Although, as I'll show subsequently, we do not recommend that you take those medicines before the vaccine because you might reduce your antibody response levels. Next slide. And I want to point out, talking about safety, for those of you who have been vaccinated, I'm sure you're aware of this V-Safe program. It's a smartphone technology that'll actually connects you with the CDC and asks you questions about your reactions or your side effects. And it's extremely helpful because it's allowed for long-term assessment of the tolerance of these vaccines, and safety is very important. Next slide. And this just looks at some of the early data. Actually, this is literally about after the first 2 weeks or maybe the first month of the use of the vaccines. And you can see that there was the sort of highlighted column there with all vaccines, that there's a fair amount of discomfort at the site of injection, and about a third of the people had some fatigue. But again, these were relatively transient and lasted only a day or two. And some people have headaches and muscle aches and chills and fever, etc. Next slide. And this looks at a different database of adverse events. It's called VAERS. It's up on the top headline here, and that just stands for Vaccine Adverse Effect Report System. Yeah, thank you, Brittany, for doing that. But at any rate, and so you can see there's a little, I'm showing you both the Pfizer and the Mrna side effects from this VAERS reporting system. Very similar to what I showed. It's going to be somewhat less because this would be patients who actually had passive reporting of side effects to this particular system. And you can see down here, injection site pain, which is about the, I don't know, seventh identified adverse event, was only 9% or 11%, whereas in the in the VSafe, it was like 70 or 80%. But this just reflects the fact that these were probably more severe site pain efforts than what was showed earlier. Next slide. And I want to make a comment because many of you may be concerned about this thrombosis that occurred with the J&J vaccine. Last month on the 13th of April, the FDA actually paused the vaccine trials, or actually use of it. Shouldn't say the trials because they were being used already because of instances of 6 cases of patients who developed cerebral venous sinus thrombosis. This would be a blood clot in the brain out of almost 8 million doses that were administered. These were all in women, relatively young women between the age of 18 and 48. Subsequently, after they paused it, they were able to identify 15 cases. The rate was 7 per million in women under the age of 50. However, when the FDA looked at the benefit risk ratio, they predicted that there would have been 116 deaths per million without the vaccine. So they reinstated the J&J vaccine, indicating that the risk benefit strongly favored vaccination. And another study came out about that time, which showed that there was a much higher incidence of these brain blood clots in patients who had COVID-19 rather than in the vaccine. So that getting the vaccine, and if you reduced your chance of getting COVID-19 by getting the vaccine, you reduce the incidence of the cerebral venous sinus thrombosis. Next slide. So I want to go over some sort of characteristics of some of these viruses, or at least some of the recommendations of who should receive the vaccine. And I'm actually going to respond to several questions that we've received. One of the questions is, well, if you've had a history of SARS-CoV-2 infection or COVID-19, should you get the vaccine? The rationale is that if you had natural infection, you would have a degree of immunity, and that is true. However, what is very interesting about this infection is that antibodies that are developed after the vaccine are much higher than after a natural infection. And so the thought is that you're going to have a much greater protection and more durable protection with getting the vaccine, even after you have had SARS-CoV-2. So we do recommend that patients who have had COVID-19, once they're out of their acute illness phase and they're no longer in isolation, they can go ahead and be vaccinated. Many of you may have heard that early on, it was stated that maybe these patients may want to wait 3 months, but that was when there was a limited supply of the vaccine. And we thought, well, because these patients have some degree of protection and immunity, let's give the patients who or persons who don't have any immunity the vaccine first. But now that since there's no limitation of the supply, we do recommend that patients who receive who have had prior COVID go ahead and get vaccinated at any time after their acute illness. Now, there's one caveat to that, and this is a guidance that was just put forth by CDC last Friday, and that is if a patient, particularly a child, let's say now between the ages of 12 and 15, or even adult, because this can happen, who have this syndrome called multi-system inflammatory syndrome, where you have it's fairly rare, but you have a serious complication where you have multi-system involvement, often with the heart and the lungs and the brain and skin rashes. And you would know if you had that. It is recommended that you wait 3 months if you've had that manifestations of COVID previously. Next slide. And then a big issue is pregnant women. The CDC does recommend that pregnant women may receive the vaccine. We do know that pregnant women who develop COVID-19 have a higher risk of severe disease or illness, and also a higher rate of preterm birth. So you'd want to prevent that. And so both the American College of Obstetrics and Gynecology and the Society of Maternal Fetal Medicine do support the use of the vaccine in women. Next slide. And I think I'll skip this slide. Go to the next slide. Because I want to show this V-safe data, because this is data early in the administration of either the Pfizer or the Mrna vaccine, but this looks at pregnancies which were reported by this V-safe smartphone system. And at least earlier, again, if you look at the date down at the bottom of the slide, this is data as of end of January, so it's several months ago. But then there were 15,000 pregnant women that were in this database, and there were no untoward, unexpected adverse events in these patients. I mean, obviously, when you start immunizing hundreds of thousands of pregnant women, you're going to have occurrences that would occur normally in pregnant women, but there have been no increases in any of these untoward effects in patients who have received the vaccine. And I want to point out that there's a lot of concern, or there's been a lot of reports in social media that maybe the vaccine and the antibody that's developed by the vaccine can be associated with infertility. And that is absolutely false. And if you look at women who have had COVID-19 with natural infection, where they've developed those same antibodies, there's not been any issue with infertility. Next slide. Other considerations, what about the effectiveness in various populations? Because in the clinical trials, certain patients who are at high risk were not included. But patients who had comorbid conditions, heart disease, lung disease, obesity, etc., kidney disease, they were included, and those patients had relatively high efficacy rates. Also those in elderly. Now, certain patients, however, who were not included, such as patients on cancer chemotherapy, patients who had transplant immunosuppression, patients who were on these biologics for like rheumatoid arthritis or Crohn's disease, we do know that there can be some reduced level of antibodies in these patients, but still we think that it's still going to be very beneficial for these patients to receive the vaccine. And now what about the effectiveness of mutant variants? Again, I'm going to focus this a little bit later, but let me just say that right now that mutations are common in these viruses. The predominant variant in this country is this B117, which is the one that originated in the United Kingdom. And I'm happy to say that the vaccine is very effective against this. Even the South African or the Brazil or even the India variant, the vaccines will have effect. Now this bottom point's already changed because it says, well, I need to wear masks after being vaccinated. Well, a week and a half ago, the answer was yes. Now, as you know, the CDC just last Thursday provided new guidance to say that if you've been fully immunized, which means 2 weeks after your last dose of vaccine or the J&J vaccine, then you can pretty much go back to what you were doing as far as your activities pre-pandemic. Now, there's going to be exceptions to that, and that is healthcare providers, some schools with the young children who can't get immunized, going on public transportation, etc. But going back to this answer here, the rationale for still wearing the masks as of more than a week ago was the concern of we have not reached herd immunity yet. Only about 50% of Americans have received any one dose of the, well, it's a little bit more than 50% of the vaccine, but certainly 50% aren't fully immunized yet. And there was a concern that there still could be spread until we get up to this so-called herd immunity. And so next slide, I just want to make a comment about herd immunity. And this sort of demonstrates how infections can be transmitted in a population where there is no immunity, up on that top row here where it says sustained transmission. So if you have a transmitting case, and remember, it could be somebody who's asymptomatic, and if they're not wearing a mask, they're going to be shedding the virus to people around them. And if there's a susceptible person, they could become infected. They could then transmit it to another person. And with SARS-CoV-2, it's estimated that for every person who's infected, if there's nobody immune around them, they're going to infect probably about 2, maybe even 3 people. Whereas you can see at the bottom, transmission terminated. That is, if somebody's infected and if they're close to somebody, but if they're immune, then they're going to stop the transmission. And this is what we need. Next slide is to stop the transmission, which is somewhat also included in this. So if you have a transmitted case and all the people close to them are immune, it's going to stop transmission so that some people who may be susceptible, such as the bottom part of the slide, won't be at risk because they'll be around people who are already immune. So the question is, how much immunity do we need? What percentage of the population to be immune in order to we can stop transmission? Next slide. And that depends upon the specific virus and how contagious it is. If you look at influenza, the reproductive number, which means that if you're infected, how many people else would you infect, is about 1.4 to 4. It's really more like 1.4. And so the herd immunity threshold is anywhere from 30 to 75%, probably more like 50%. Whereas measles, which is very contagious, you need 92 to 94% immune in order to stop transmission. That's why you've probably become aware of outbreaks of measles in this country when there's been a drop in the uptake of vaccines for children, which has unfortunately occurred in some parts of the country. So if you get where 10% of the children aren't being vaccinated, that's when you likely, based on this herd immunity threshold, will see outbreaks, which unfortunately we have. Next slide. Other considerations, I already mentioned this. Should I take ibuprofen or acetaminophen prior to the vaccine? And the answer is no, because that can reduce the immune response. But it is safe to take ibuprofen or acetaminophen or similar medications after receiving the vaccine when you develop symptoms. That is okay, because when you've developed symptoms, that means you've already developed a good antibody response. Now, if you're a pregnant woman, then you wouldn't want to do the ibuprofen, but you could use acetaminophen. And by the way, the ACOG, that initial at the bottom of that slide, it stands for the American College of Obstetrics and Gynecology. And the AAP on the bottom line is American Academy of Pediatrics. Next slide. Should I stop regular medicines? Basically, no. We do know that some of the immune or some of the medicines that affect the immune system, like I already mentioned, patients who have rheumatoid arthritis may be on some of these biologics that can reduce the immune system. Actually, that's what they're supposed to do in order to reduce the manifestations of rheumatoid arthritis or Crohn's disease. What we can do, since these are administered intermittently, you can give the vaccine, different from when you're giving the immune modulator. And a lot of the rheumatologists or gastroenterologists will do that. And talking about how we administer the vaccine with other medicines, I want to make a point here as well, which I don't have a slide of, but initially it was felt that the COVID-19 vaccine should not be co-administered with other vaccines, and they should wait at least 2 weeks. If you had one other, like say you had a shingles vaccine, and then wait 2 weeks to get the COVID vaccine, or if you had a tetanus toxoid, you should wait 2 weeks. Well, as of last Friday, the CDC has changed their guidance because there's new data to suggest that we can co-administer these vaccines with other vaccines. And that's particularly important when we talk about the adolescents, or the 12 to 15 because age group, because they may need to receive other vaccines if they're going to college, or receive the human papilloma vaccine or whatever. And we don't want to necessarily make it difficult for them to have to go to their care provider multiple times to get all these vaccines. Now they can get them at the same time. So that's going to be very helpful. Next slide. Oh, this has totally changed because, again, this is from 2 weeks ago, or a little bit more than that, about what you can do. Now, as you know, if you've been fully vaccinated, as I've already said, you can pretty much go back to activities prior to the pandemic, with certain exceptions that I've already mentioned. Next slide. Now, talking about these variants, just very quickly, I mean, if you look at the bottom row here where it says vaccine resistance, I'm looking at what the variants, what is their impact on the ability of the vaccine to be effective. Now, one point I want to make is that we've been dealing with variants for over a year. That first column, which says GI614G, this is the strain of COVID or SARS-CoV-2 that we've been dealing with. The world has actually ever since last June, because it's different than the original Wuhan strain, but it really didn't have any effect on the vaccine resistance. Also, the B117 has very little effect on vaccine resistance. And that is predominantly what we see in this country now anyway. The South African and Brazil, which are the next two, there's a moderate to low to moderate reduction in antibody neutralization. However, still, the amount of antibodies that are developed with these vaccines are high enough that they have good effect against certainly preventing severe disease. And then if you go to the India, which is the last one, again, it's somewhat similar to the South Africa. There probably is a reduction in the neutralization effect of the vaccine, but still we have enough vaccine titers that have been developed or stimulated that we have effect even with that as well. So the point is we need to get more people vaccinated so that we can reduce the transmission of these variants. Next slide. And this is from the CDC. It looks at the sequencing of the various viruses that have been identified in the United States. And you can see that by far and away, the most predominant one is B117. I've got it highlighted on the right-hand part of the slide. Literally, now it's up to about 70% of all of the lineages in this country are the B117, which in a way is good because the vaccine's very effective against that. And if you look at the B1351, which is the one that I highlighted below, sort of in the middle of that table, that's the one from South Africa, but it only represents about 1% of the strains in this country. So that's good because that's the one that might have a little bit of effect on reducing the benefit of the vaccine, but still, it's still very good. Next slide. And then the question we often get is, well, how long is this vaccine going to last? This is a study that was just published about 2 weeks ago. It looks at specifically the Pfizer vaccine, and it looks over the first 6 months, and you can see it's looking at antibodies to what's called the receptor binding domain. That's where that spike protein actually attaches to the receptor site. And you can see that the antibody levels still are high, even in patients over the age of 71. So that's good. We don't know how long this will last, but studies are ongoing. So we will know as time goes on when and if we need a booster. But right now, certainly after 6 weeks, there's still very good vaccine efficacy and it remains high. Next slide. And this sort of illustrates the effect of the vaccine in reducing the amount of virus that we're seeing in cases. Because on the left-hand part of the slide, in the darker areas or the shaded areas represents the percentage of positive COVID cases December 1. So that's before we started mass vaccination. Then the second one on the right is from March 1. So you can see much less shaded areas showing significant reduction in number of cases of SARS-CoV-2 or COVID-19 because of the vaccine. And as I said earlier, this is the way we're going to be able to get over this pandemic and get the whole country without any shaded areas whatsoever. Next slide. Now, I mentioned India, and you're probably aware that there's a big outbreak in India right now. And you can see on that bar graph on top that the incidence of cases is going up significantly. If you look at the bar graph on the bottom, it's all due primarily to that one India variant, which is highly contagious and causing this infection. The problem is that in India, there just has not been a high level of uptake of the vaccine. Next slide. And what this shows is countries and the relative percentage of their population that have received the vaccine. So you can see Israel's up to over 60%. United States is about number 5, and it's, well, when this was done, which was May 6th, more than a week ago, we were at about 44%. Now we're closer to 50%. But if you go down to the bottom, you can see India was less than 10%. And if you look at those that were fully vaccinated, it was definitely less than 5%. And so that's the problem there. And why there's still this surge, because you haven't had enough of the population vaccinated and therefore immune to be able to stop or reduce the spread. And that is important because we really need the stop of the spread in all parts of the world to be able to feel safe in every other part of the world. Next slide. And this just sort of illustrates this. I mean, the areas of the world that are darker are associated with those that have higher rates of vaccinated population. Those that are light have low rates of population. And that's what we need to focus on, is getting everybody vaccinated, because, you know, any infection in any part of the world is only a plane ride away from wherever you live. And so we have to think globally here and make sure that we reduce the spread all over the world to be safe everywhere. Next slide. And then this looks at, again, at the United States, the percentage have received one dose. If you look at the left-hand part of this slide, it looks by age. And this is important because you can see that 65 and older, you know, about 75% have received the vaccine. This is really important because we don't see older patients coming into our hospital anymore. We see the younger people. Where we're seeing the transmission is adolescents to about age 40. And that's where you can see on that left-hand part of this bar graph where we need more of this group immunized. And then we have to acknowledge that there is a gap based on ethnicity and race. And on the right-hand side, we're looking at those characteristics. And it's important, again, to get everybody who's at risk immunized to protect everybody. Next slide. The last point I want to make is about barriers to vaccination. I mean, we have the vaccine, we have a good supply, everybody has access to it, but only about 50% have been immunized. So why is that? Well, there's sort of two issues. There's vaccine hesitancy, and I can understand that. This is a relatively new vaccine. But if we ask why people are hesitant, we can usually address their concerns through education. And then there's these anti-vaxxers. Unfortunately, there we're dealing with misinformation. And it's very difficult to rationalize with them. But I would say 2/3 of the patients who have not received the vaccine, it's because of hesitancy. And I think we can deal with them. Next slide. And I want to show you, this is a recent study out of the University of Pittsburgh, but it looked at all the reasons why there is hesitancy. So, and I've highlighted some of these. So number one, they're concerned about side effects. Number two, about they don't trust the COVID-19 vaccine, that is too new, that it's too new technology. But I've already said that the studies were done under very stringent scientific criteria. The next one I've highlighted is I don't believe I need it. I'm healthy, but healthy people get sick too, and healthy people can transmit. And we need healthy people so that we can increase the percentage of people vaccinated to get to herd immunity. And then down at the bottom, doctor not recommended. We have to make sure that all of our colleagues are champions of promoting the vaccines, because we know that healthcare providers are the #1 stimulus for patients to receive the vaccine. And then there's the concern about pregnancy that I've already mentioned. Next slide. And so I'm addressing all of these here. So from side effects, well, they are expected, but they're transient, and you can ameliorate them with medication. If you go to don't trust the COVID-19, well, we have to educate that these were very high quality trials, essentially high quality as you would require for approval. It's just that approval requires a much more comprehensive assessment by the FDA. But I really anticipate, actually, Pfizer has already applied for approval, and Mrna is going to apply for approval very shortly. And I anticipate that within several months, but it may be the fall, that we'll get approval, official approval. Don't believe I need it. Well, young, healthy people, if you look at the left-hand part of the slide, they are the primary source of the vaccine or of the virus right now. We got to get them vaccinated. And they can have severe disease. And even if they have mild disease, they can have this manifestations of persistent symptoms of long COVID, and we need them for herd immunity. I already mentioned those other points down below. So let's go to the next slide. So when I talk to physicians and my colleagues, I make sure that we should give strong, unambiguous recommendations to our patients or to our friends that they need to get this vaccine. Not do you want to get this vaccine, but they need to get this vaccine. Next slide. And I mentioned these long-term lingering symptoms, which can occur even in asymptomatic patients. And so this is another reason why we have to educate even, quote, young, healthy people, even adolescents who may perceive that they're not as high risk for getting severe disease, which is true, but they can get, if they're infected, even asymptomatically infected, they can have these long COVID sequelae. I'm not going to have time to go into all of these, but virtually any symptom now can be associated with a prior infection with SARS-CoV-2. Next slide. And then this is my last slide. The left-hand slide is a chart that was developed by CDC actually about 2 weeks ago. It was based on predictions of ending the pandemic based on a various scenario. But I'm just going to focus on the last scenario, which is high vaccination rate, which is over 80%, and then moderate non-pharmaceutical intervention, which basically means mitigation practices such as masks and distancing. And if everybody, if we achieve that, remember, we're only about 50% vaccinated right now. Then by July, we should have low enough transmission that the pandemic itself should come to hopefully an end. But what is the future of COVID-19? While the pandemic may come to the end, that doesn't mean the virus is going to come to the end. It just means like influenza, it'll be seasonal. And so we have to be concerned about that. And then we also have to be concerned, as I've already mentioned, the global impact, because while in the United States, it may be reduced, we have to make sure it's reduced in other parts of the world so it's not spread back to us. And so the question is, what is the percent that's required for herd immunity? You know, most public health experts say about 75%. You know, hopefully we can reach that certainly by July. I've already mentioned if and when we'll need boosters. We'll have to wait and see the duration of the protection of the vaccine, and if indeed the variants make an impact such that we will need new vaccines that will cover some of the variants. So with that, I'll stop. I'll be happy to answer any comments or questions at this time.
Dr. File, when you first started, you said that you get lots of questions. I'm wondering what are some of the common questions that you get about COVID-19 and vaccines?
Well, I went through some of those. I mean, the concern of pregnancy, the concern of side effects, and what are the side effects? Can I get the vaccine if I have certain conditions, or when can I get the vaccine after I've had COVID? These are some of the common questions, but I've already sort of answered those.
Okay.
But if there's any others, I'd be happy to address them. I'm trying to see if there's any.
You mentioned earlier that kids are less likely to transmit. Why is that?
Well, because let's put it this way. Probably the children under the age of 10 don't transmit very much, mainly because their receptor sites, to which the virus is attached, don't accommodate as much virus. And so they're not shedding as much virus. However, once you get to become adolescent, you're more like an adult. And, when I'm talking particularly loud, like I am right now, I'm distributing what we call air droplets. They're invisible, but I mean, they're droplets that contain the virus. And if I cough or if I yell, it can go many, many, many feet, 20, 30, 40 feet. If I'm just talking, it should only go about 6 feet. Then they would settle to a surface or to the ground, so that within a certain proximity, when you shed the virus, if you're infected, and remember, I could be infected without having symptoms, but I've been vaccinated, obviously. And as I already said, there's compelling evidence now that once you're immunized, you stop shedding it and you stop spreading it. But if you're not immunized, and here's the issue, like where I live in Northern Ohio, only about 50% of the population of our county are immunized. That means 50% are not. And when we stop using masks, because these mask mandates are going away in a couple of weeks. In fact, right now, most people aren't wearing a mask because of the CDC guidances. But remember, the CDC guidance says, if you're fully immunized, you stop wearing masks. And we don't know, I mean, if you're immunized or not immunized, because there's not going to be any way to document that, at least in most situations. So it's still important right now to get immunized if you're not immunized, so that we can get up to this herd immunity and actually stop the pandemic, because the pandemic is still ongoing right now. We're still seeing persistent ongoing transmission. And that's really important for people who are vulnerable. I mean, some people who have taken the vaccine, because of maybe they have cancer and they're receiving chemotherapy, or maybe they have a kidney transplant and they've had the vaccine, but we know that may not be quite as effective there. So they potentially are vulnerable. And we need to have a high percentage of the community immune so that we stop spread and so that we don't spread to those people.
Anybody else have any questions? You're all so quiet. I'm wondering if you were in charge of marketing and promoting vaccines, what would be your top 3 ways that you would, or even just the best way to do that? I mean, we get mixed messages all the time. Misinformation, like you said, is like a major deterrent for people getting vaccines. How would you address vaccine promotion?
Well, like I said, I mean, when we talked about hesitancy, I mean, it's important to go over, education and, the 2/3 of the people that are hesitant versus the 1/3 that are anti-vaxxers. I think we can make some headways there, and we just have to appropriately give them information. The problem is it's not easy to do. Like if I was marketing to a mass group, I mean, I can do it on a one-by-one basis. I mean, I had one of our directors of our hospital who was very hesitant call me yesterday and said, "Dr. File, can I just pick your brain for 5 minutes because I'm concerned about the vaccine?" Well, after 30 minutes, it took me 30 minutes to finally give him all the information. I mean, his primary concern was that this is a new vaccine and we don't know a lot of information about it. And that's probably one of the main questions we get. And so we tell them, as I mentioned in the presentation, that although the mRNA is relatively new, it's been in development for about 20 years. And the studies were done very carefully. As a matter of fact, I was on a call last week that included the director of the center that evaluates vaccines by the FDA, who indicated we really have more data now on these mRNA vaccines than most vaccines that we approve. And it is very safe and it is very effective. And we need to take advantage of this, because to have a vaccine that's 95% effective is truly remarkable. And so, and that it is very safe. The FDA, and that's what people are concerned about, is it really safe? I mean, the FDA did not authorize this until the majority of the recipients in the clinical trial were 2 months after their second dose. Why is that? Well, if you look at other vaccines that have been approved, 90 to 95% of all the long-term effects have been identified within 2 months. So, we should feel somewhat confident that, this is going to have long-term safety. And then the other point that I think finally got to him was, I said, look, if you get the vaccine, well, first of all, do you have children? And he has children and he has a wife. Now, his wife has been vaccinated, but there's been several hundred children under the age of 10 who have died due to COVID. Now, I understand, people will say more people die from influenza, children, but influenza we didn't see this year, which is an amazing observation of the benefit of wearing masks, right? But I said, children can get sick And so you want to protect yourself, you want to protect your children and your family, you want to protect others around you, and very importantly, you want to protect the hospital, because we don't want outbreaks within the hospital. And so finally, he said, well, he'll go get the vaccine. But so, I mean, so education is number one, but how do we educate? You know, there's all kinds of TV ads about, you know, trying to draw sympathy on, you know, your altruistic situation that, you know, getting the vaccine not only helps you, it helps the community. I think the other thing is getting the vaccine, you know, certainly 2 weeks ago, I think this would have generated a lot of incentive. Getting the vaccine gets you back to normal. Okay. But right now with this, with all of these mandates being lifted by, you know, 2 weeks from now by most states, and some states have already totally lifted them, you know, there's maybe a less of incentive there. Of course, in Ohio, as you know, we've got the incentive of being put into a lottery. At first, I was kind of sort of, I wasn't sure how much that would be incentive, but I guess it has. I mean, from what I read, that it has increased the last day or two vaccine uptake. So if that works, great.
Great, thank you. There is a question in the question box. It says, can you speak to the percentages with regards to vaccination in communities of color or vulnerable communities? Is there still a great deal of hesitancy, or is that starting to change?
Yeah, and that's a good point. First of all, I should say that you know, some of the different ethnic or racial groups have higher rates of complications, so it's really important for them to be vaccinated. And quite honestly, it's not genetic. It's just that there's maybe a higher rate of some of these underlying conditions like obesity or whatever, or even hypertension. But particularly if you look at the Black community, I mean, you can see how there's going to be some natural hesitancy from some of the issues in the past, and they have, in a sense, a greater concern about the development of the vaccine, etc. But as we educate them and we go out, because I've given presentations to many of our neighbors in those communities, and as we educate them, they also, I think, are, you know, appreciate the vaccine and the benefit of the vaccine.
And another question is, do we know when kids under 12 will be eligible for vaccine?
Yeah, actually, from what I understand from the FDA, well, they're doing studies right now, both Moderna and I think even, I'm not sure if J&J is, but both Moderna and Pfizer are doing studies 6 months to age 12. And according to my source at the FDA, they would anticipate that it would be authorized, that they would have the data by late fall, early winter.
All right, and then here's another one, and there's a couple parts to it. So what are your thoughts about campuses when they return this fall? What recommendations / mandates for vaccinations should there be for students that reside in groups? And what about for students who are not vaccinated, who commute or refuse to vaccinate?
Yeah, I mean, these are issues that are going to have to be resolved over the next several months. And we have to remember this is authorized vaccine, it's not an approved vaccine. But I know a lot of universities, particularly private universities, that may not be under the auspices of the government restrictions or whatever policies there might be, are going to request that, or mandate, I guess, or require, I guess that's a better word, that students be vaccinated, and that they have to show evidence of vaccine. I would think also that in that case, they would have to provide the vaccine as well. I mean, for the students, if they didn't have access otherwise. It seems to me that there's going to be several options. You could have students coming to in class to the dorms if they're vaccinated, and if they choose not to be vaccinated for some reason, that they still would have access online like they're doing right now. Or, you know, some colleges may require that they're only going to have in-class lessons, and that you would have to be vaccinated. So we'll have to see how those policies proceed. I know there's going to be other events and other activities where there's going to, at least they suggest that you have to show evidence of vaccine. The only problem is, you know, documenting the true vaccine status. How's that going to be done? I mean, if you do it by a card, how valid is that card, etc. So I think these are very good questions, and they're going to have to be answered. But I can tell you this way, if everybody gets vaccinated, then we won't have to worry about that, because then the pandemic will be gone and we'll all be safe.
Great, thank you. You were talking about boosters and things like that for, or maybe possibly follow up to vaccinations or initial vaccinations. How is that different? I guess I'm just curious about, you know, the flu vaccine is something that people get every year. Yeah. So how is this vaccine unlike that, or will it become like that? Although, you know, when I take my kids for vaccinations, you know, once they reach a certain age, they only need a booster for some of the vaccinations they have. Is it because this virus acts more like those types of viruses?
Well, there's some differences here. As far as influenza, the reason why we really need yearly vaccine is because the virus actually changes much more than these variants. The variants is just a little minor change in the actual virus, but the influenza actually changes. And there's different types of influenza. There's influenza A, influenza B, there's influenza A1, influenza H1N1, H3N2. These are totally different viruses, although they are in the family of influenza. And then they can change. And so every year we can predict, based on what happens in the southern hemisphere, what we're going to see in the northern hemisphere as far as the strains or the types of influenza vaccine. So that's a different reason why we need to have annual flu vaccine, is because it's a different virus the next year. This is not going to be a different virus. It may be a different variant, but it really is going to depend upon the duration of protection. And we're really going to know that as data is being accumulated right now on patients who have received the vaccine, persons who have received the vaccine, and then develop breakthrough illness. Because then you're going to be able to correlate what the level of immunity is in those persons, and then be able to give direction of when we may need a booster. So it's going to depend if SARS-CoV-2 does become seasonal, which I suspect, and I think it will, as another respiratory virus, like influenza, like many other respiratory viruses. And if it is going to be associated with severe disease, or does it morph into our other endemic coronaviruses that just causes the mild cold-like illness, in which case we wouldn't need a vaccine. So, you know, again, time is going to tell. Data is being accumulated right now, so we'll know about what we'll need for boosters as that information becomes available.
And then I have, sorry, I just really curious, and I have another question. So those people who have contracted the virus, I think they're often called long haulers, where they still have, yeah. If they receive the vaccine, will that help, I guess, with their symptoms or what they're dealing with?
Yeah, that's a good question, Juliana. Actually, there were some anecdotal reports of people who had these long-term persisting symptoms, got the vaccine, and the symptoms went away. But you'd have no idea if that would have been the natural course anyway. You'd have to do a randomized trial on some of these persons. But the problem is these long-term persisting manifestations are so heterogeneous that it's going to be hard to develop a clinical trial like that. And quite honestly, we still don't know a lot of the information of why these patients, because it's hard to predict which patients are going to develop these. Is it because they were sicker, or they were younger, or they were older, had more underlying conditions? It's just really unpredictable right now. And so there's a lot of unknown questions about these so-called long haulers or post-acute COVID sequelae patients. And so right now, we would recommend that they get the vaccine, mainly because we don't want them to get reinfected because they can if they just had natural infection. But we have no information or data to support the fact that the vaccine will eliminate these long persistent symptoms.
Well, I guess I hear two themes: get vaccinated,
Right.
and more to come, more information to come as we learn more as time moves on.
Yeah, and I would just want to reinforce, I mean, these vaccines, it's remarkable how safe and effective they are. So, and it's definitely been shown just in 6 months how we've been able to reduce the impact of morbidity and mortality. We just need to get boosted up a little bit to be able to end the pandemic, because the pandemic is not done now. We can see how to do it. So we've got to, everybody has to do their part. And like I said, protect themselves, protect their families, protect the community, and get vaccinated if you haven't been.
Yes. Any more questions for Dr. File? Brittany, could you pull up the slide with the Dr. File? First of all, thank you so much. This has just been so informational. When I look at the slides and I hear you talk about the information, I'm just like, wow, can I just have this on like a business card, start passing out to people? Or I know that I will use this information to inform. Thank you, Brittany. To inform, kind of like, you had your conversation with one of your colleagues about the vaccination, and maybe that is going to have a greater impact as that personal one-on-one, So thank you anyway for your expertise. It's very good.
My pleasure. And I wish everybody to be safe. And as we go into the summer weather, let's all be able to, enjoy it. And we can enjoy it best if we're all vaccinated.
I agree. And it just feels better.
That is true.
So if nobody has any more questions, I think we're good. And thank you for participating. And as always, if you have any questions, OCI specific, please feel free to reach out to me via email or phone.